It's a quite complicated procedure. The procedure has several parts during the whole process of movement. So the first thing is that the motion has been planned. The planning is made by the central nervous system mainly, and then the motion has to be programmed, so it has to be set a direct program what to be have done, because many parts of the muscles, skeleton and coordination of muscles has to be involved into the execution of the motion. So when the motion is under programming, then starting the execution of the motion, the real execution of motion. But because motion is a very frequently movement of more muscles, more parts of muscles, there is important also to do some follow-up of the motion. The follow-up is interactive, and the motor system is under control how the muscle is moving, how it's contracting, how the joint is moving, how the muscle is under tension, and also how the tendons and ligaments are under tension, or what is the intramuscular pressure, etc. So then we have two systems which are partially acting during motion. So it's a motor system. Motor system is the executive part, and the somatosensoric is a feedback part. So those two are on the middle and third of the motion. The first one, the planning and programming is typically done by central nervous system in the brain. So which structures are acting during the motion execution? So the programming is important, that is starting in the frontal and also in the temporal and parietal lobes. So this is something which is then guiding the system which is preparing musculoskeletal system for the motion execution. Sorry. You cannot hear me? Now it's better. The sound is not working. And now it's better. So someone probably decreased the voice loudness. So this is the important involvement of the subcortical structures, which are two. The one is basal ganglia. Basal ganglia are motor system preparing, which are under control of a cortex, and they prepare the tension, proper tension of the muscles. And then also the important is cerebral hemisphere, so neocerebellum, because it is the coordination of the motion preparation, and it is one of the most important players in a coordination of motion. So then, in the second, in a programming, those two structures, neocerebellar and basal ganglia, give some information, proper information to the sensoric and motor cortex along the central sulcus. So precentral is a motor, and the important is also the information about the proprioception from a post-central gyrus. Then also the premotor cortex is something which is really fine-tuning the programming of the execution, and the own execution is then guided by the activity of the motor neurons which are localized in the precentral gyrus. Precentral gyrus contains the giant Betz pyramids, and axons of those pyramids then send the information and send the guiding impulses into the spinal cord, and the spinal cord then conducting the information in two parts, in pyramidal tracts, lateral corticospinal and anterior corticospinal tract, to the spinal cord. And in a spinal cord then the information is transmitted to the anterior horns, where are motor neurons, and those motor neurons transmit the information to the muscle. And then backwards there is a very important second phase where is a feedback, and the feedback is made typically by the cerebellum, by the middle part of the cerebellar hemispheres in our cerebellum. So then cerebellum is the most important, which is taking the information made by so-called unconscious proprioception. So for motion execution we have to use almost the whole neural system, central, peripheral, and also transmission to muscles. So planning, where is the planning? Planning of the motion is typically in a prefrontal cortex. Here we have our center of a behavior, because this is now when you are boring by my lecture. So you are planning now that you are hungry, so you will go to the cafeteria, etc. So this is a mind which is planning the behavior, and then behavior is also planned in association with some association cortex. Also, there is a very important input, because why you are boring? Because you are viewing those strange slides, or you hear your colleagues that she or he is also hungry, and you will go to the cafeteria. So those are association inputs which are from the outside, from the body, typically from visual and hearing impulses. So then the motion is programming. The second phase is programming. Programming is then at first done by prefrontal and supplementar motor cortex, which is lying in the front of a primary motor cortex. This is a primary motor cortex, precentral. The precentral is the execution one. So the planning is then done that the cortex has projection to basal ganglia. You know that basal ganglia then have a way which is through the medial part of them, so from striatum, from putamen, the inputs from the cortex are then transmitted to the other parts, to the reticular and compact part of the substantia nigra, and then also this is inhibiting the medial part, which is a globus pallidus, through the direct or indirect way, and subthalamic nucleus is then activating back the putamen, but the subthalamus should be slowed down and suppressing by this inhibitory way. So this is the proper way how to be properly the muscular system under tension. So this is the most important. This is like a string. When a string is in a proper tension, it could produce a sound. When it's not useful. So this is the main principle of this. The principle is that the cortex is stimulating putamen, and putamen then is transmitting this information to the subcortical and subthalamic centers, which should be in proper way stimulated. Here, the acting substance here is dopamine, and with the dopamine connections, the proper tension is also done because it is suppressing the stimulating wave through the subthalamic. So this is the important way. The second way from the basal ganglia is then the suppression of a thalamus, because the thalamus is a stimulating cortex. So here are plus ways, and basal ganglia then should also suppress the activity of thalamus. So the proper way is that we have the right tension of a muscle, not too much, not too low. And this system, when it is involved, typically we have some problems. I have said to you that we have some involuntary motions, involuntary tension, typically in Parkinsonian disease or chorea major. So basal ganglia, once more, we have then before. So basal ganglia are divided in two parts. One is called neurostriatum. Neurostriatum is typically, so when we look for only motion, so it is a neurostriatum. So it's a caudate nucleus and putamen, and then we have a globus pallidus or pallidum. This part, the medial part, is then connected with the other structures which are in a subthalamic and also in a mesencephalic region. So neurostriatum is the interrelay from a cortex. So from cortex they obtain the input, and then the input is then transmitted to the medial part of basal ganglia, to the globus pallidus, directly or indirectly connected through the subthalamic nucleus. So I have said that we have some direct, indirect and hyperdirect pathway. So this is a communication between cortical and subcortical centers planning the motion. So from cortex we have connection to the putamen, which is typically excitatory. So from putamen we have two ways. One way is through the medial part of the globus pallidus. So this is globus pallidus internus, and then it is connected with subthalamic nucleus, and subthalamic nucleus is typically increasing the activity of the internal globus pallidus. And then the globus pallidus, the medial part, has important inhibitory connection to ventrolateral nucleus of a thalamus, and then the decreased activity is controlling the connection to precentral sulcus, the sensory information from thalamus, then stimulating or manipulating with the activity of the neuron. So this circle is maintaining the proper activity of a muscle. So when we go to the next part, we have planning in the mind, preparation of the motion through the proper tension of the muscle. Then we skip to execution. The execution then is, I think, the most easier to understand, because we have prepared the plan, we have prepared the muscular system, and then the right impulse now is going, and this is a pre-central gyrus. And then it's depending on the region where we have to perform the motion. So when it is, I am now talking, so my most neurons are guiding the muscles in my throat and in my face. Then we have the gyrus, and we know that here is a face is down, and then arm is in the middle, and then on the top and medial part is a leg. So then the execution of the motion has a way with the band of white matter. There are axons. Typically we can see it in the posterior arm of the internal capsula, and through the corticospinal and corticonuclear tract, this is going this information to the nuclei in a brainstem or into the anterior column of the spinal cord. Where is the way of this corticospinal tract and corticonuclear tract? Corticonuclear is for cranial nerves, so it is ending at the nuclei, which are localized typically in the brainstem. In mesencephalon, there are third and fourth nerve. Fifth is in pons varoli, and the rest of them, or the nuclei, so 6, 7, 9, 10, 11, and 12, they are in a medulla oblongata. So then, here we have the somatotopic distribution of the white matter in capsula. So very important is, again, to be oriented. Here is the anterior, and here is the posterior. So it's like in anatomy, not like in CT or MR. And this somatotopic organization then is the same in mesencephalon, in so-called cerebral peduncle, so peduncle. And you can see again the organization is the same. Then the cortical part, corticospinal tract, a part is then crossing, a part is not crossing, and we will know it in some seconds how many fibers are crossing. And then again the corticospinal tract has a somatotopic organization which is in a cervical cord in a lateral cervicospinal tract. The lateral cervicospinal tract has the parts, so the lateral, it's easy to remember, lateral is leg and medial is arm. So this is also somatotopic organization, because the whole somatomotor system has a topic organization. Those fibers are not crossing, they are not changing position. So this is a very well organized system. So, except corticospinal and corticonuclear tract, so they are very easy to understand. They are from precentral gyrus, there is a first neuron, the second is a nucleus, for example, nucleus nervi trigemini, motor nucleus, and then the second neuron is then going to the proper part, to the chewing muscle. The second is in a spinal cord. In a spinal cord, this is also first neuron is in a cortex, the second is in anterior horn, and then it is stimulating the muscle, for example, musculus biceps brachii. But we have also extrapyramidal tracts. Those extrapyramidal tracts are those which have no distinct and direct way to motor neurons, and those systems are helping to organize some, I have to say, not non-voluntary motions, but automatic motions. Those are which are reacting to the surrounding situations. For example, fixing the object which is moving around you, or if you hear some blasting thing, or the window is broken, such information from auditory system. Also smelling system, which is then also the input which could guide us to some automatic motions during feeding, during defending, and etc. And also they are some emotions which are automatic, like you probably know the quadrupeds, like they are walking, then the horse is walking, then is running, and different ways of running. And those I think the frameworks of the motion, those automatic are not under full guidance of this planning system, corticospinal. This is not planning by the prefrontal cortex and the association cortices, but it is guided directly from the inputs from the other structures. So the most important in motion are red nucleus, localized in the mesencephalon, and then also the important nuclei are nuclei which are localized in the oblongate, and typically it's in a olivary system, so olivary, and then also colliculi, so colliculi, they are tectum, And then also, very important is the input from reticular formation and also the most of motions is under guidance from cerebellum, from fastigial nucleus, from the old part of a nucleus. So then, those extrapyramidal tracts could be known like rubrospinal, then tectospinal, olivo, and reticular. Almost all information from cerebellum, and also have some information from vestibulocochlear system. So it's going through the olivospinal system. So what is the rubrospinal system? Rubrospinal system is stepping, for example, stairway. The tectospinal is a visual input to the motion. Olivo is a balance, and other cerebral and auditory system guiding system. And reticular spinal, so it is when you sleep or wake up. So then, this is a guided motor system. When you are sleeping, your muscles are relaxing. Or they are moving some way when you are under REM phase of the sleeping. So then, those tracts are also modifying the motion execution, but they are some automatic systems, more or less automatic. More automatic is a reticular, less automatic is a tecto and olivo, because it is reacting to the position and the outer inputs, and the most complicated is a rubrospinal tract. Also, nucleus ruber is under control of a cortex, because we have also corticorubral tractus, which is guiding the red nucleus. So, when we discuss about the motion problems, we very frequently could see the effect of the ischemia to the systems. And very important is the localization of those tracts. So tracts which are localized in the posterior. Here is again posterior, and here is anterior. The posterior tract, corticospinal tract, we have here two, and those are corticospinal in the posterior limb. In an angle of anterior and posterior limb, there are corticonuclear tracts, which are guiding then the motions of head and neck muscles. Head and neck muscles in relation to the cranial nerve innervation. So then we can say this is the motion really mimic muscles, swallowing muscles, muscles moving with the voice organ, and muscles which are chewing. So those are. And very important is then also the guidance of a nucleus ruber, because there is a very interesting and important input for the learning some automatic machine-like motions, like, as I said, stepping on the stairway, bicycling, or other, which are not completely under your mind control, but a little bit yes, because you have to learn the motion. So motor cortex. Motor cortex and the topic localization. So we have the organization of the body. The head is and head in the relation, the tip is down, tip is down, what is the most anterior. If you can imagine the snake, what is in the front of the snake, it is his or its tongue. So the tongue is the base, and then it is a face, frons, thumb, hand, arm, trunk, lower extremity, thighs, and the foot is the last, which is on the medial part of the precentral cortex. Those neurons, where I here, produce axons, very, very long axons, and those axons then have outputs. So the outputs are partially then to the corpus striatum and thalamus to have a feedback for those structures. Then is guiding red nucleus. We have heard about the automatic motions, and then they have a real impact to cortical nuclei, and also they have inputs to the nuclei which are in oblongate. And we know that in the oblongate we can find the structure which is like St. Andrew cross, and this St. Andrew cross is a side where are crossing those fibers. This is on the anterior part of the oblongate, and those fibers which are here crossing, the structure is called decussatio pyramidum, pyramidal decussation, where are about 80% of all fibers crossing to the other side. The rest, 20, are going on the same side. So then we have a lateral corticospinal tract which contains crossed fibers, 80% of all. And the rest is anterior corticospinal. This is a 20% only. But they are also crossing to the other side, but they are crossing on the level where are the motor neurons which are stimulated in the anterior horns of the spinal cord. So then we can say that we have 3 direct tracts which are motor. Those are corticonuclear tracts which are stimulating cranial nerve motor nuclei, typically those which are moving with the eyeball. Then also, for example, for the tongue, it is a 12th nerve, hypoglossus. So they are corticonuclear fibers. Those corticonuclear fibers are dividing at the level of the brainstem and forming the tract only in the capsula interna. Then through the capsula interna, they are formed 2 tracts which are going down to the spinal cord. And they are called lateral and anterior corticospinal. So lateral is crossed, anterior is uncrossed. So lateral is crossed and this is uncrossed. So when we look at the spinal cord organization, so here are some ascending and descending tracts. For motor stimulation are here in the red Those pathways are going down and they are pyramidal. We know them now. Pyramidal is a lateral, crossed, and anterior, which is uncrossed. The lateral has this organization, as I said, this is a sacral, lumbar, thorax, and cervical spine. So it's a lateral is a leg, trunk, and here it's a arm. Then we have rubrospinal tract. Rubrospinal tract is localized anteriorlaterally from the cortex, from the corticospinal tract, and there is a rubrospinal tract is then stimulating neurons for those automatic motions. So this is automatic. Then we have two reticulospinal tracts. One is anteriorly, and the second is on medial. And then we have two other olivospinal and vestibulospinal tract. The olivospinal is from olivary, vestibulospinal is from vestibular system, and vestibulocerebellum, so this is cerebral downstreaming the tract. So those extrapyramidal tracts are here important. Some atlases miss olivary or vestibulospinal tract. Some miss, like here on the schema, which is from Wikipedia, miss the one which is a tecto. But in general, in anterior column, we have motor neurons, which are the guidance of a pyramidal and extrapyramidal. From extrapyramidal, the most important for us is rubrospinal, which is laterally localized, and anteriorly, in anterior fasciculi, we have tracts which are going from the oliva, from the vestibulo, cerebellum, from the tectum, and from the reticular formation. So those are those which are preparing our system for the motion execution. So what is happening on the level of the spinal cord? On the level of the spinal cord, in the anterior horns, we have several groups, several nuclei of motor neurons. Here we have a more prominent population, which is more anterior and more medially in anterior horn, and they are medial group, which is alpha motor neurons. Alpha motor neurons are stimulating the neurons which are directly executing the motion due to stimulation of strip muscle. The strip muscle tissue. To do contraction of the whole muscle, or sometimes the group of neurons, group of fibers, then the larger group, the whole muscle, and moving, for example, with biceps. Then we have a lateral motor nuclei group which has gamma neurons, gamma motor neurons. Gamma motor neurons are motor neurons which are stimulating the muscular spindles. Muscular spindles are made, and we will have one image, specialized fibers of a strip muscle which are able, according to the contraction, according to the distension, produce information about the force, so the intensity of the contraction, and the other important information about intramuscular tension, etc. So this is gamma motor neuron, and the gamma motor neuron then is properly setting this device to be able to produce inputs according to the back information, to the feedback information from the muscular system. So, motion sensation. Motion sensation is then the feedback. The feedback is very interactive because the motor system is guiding the motion properly, not like one impulse. The impulse is correcting, because if you would like to touch to something and something is moving with the cat is hunting mice, so the cat has to decide which mice to hunt, and when device is decided to catch one mouse, so then it is needed to coordinate the motion, and when the mouse is running out, so the motion has to be modified. So it's roughly the same, because the motion of the muscle is a line of events which are under control of the supervision. So we have two important information obtained from a musculoskeletal system, which are both called proprioception. Proprioception is a sensation from inner space, inner environment of a musculoskeletal system. One is conscious, and the second is unconscious. Conscious is what we can feel, really, in our mind, directly or indirectly. The unconscious or unconscious is the information sent to the cerebellum, where is localized the position of the muscle, position of the bone, and then the system, for example, the whole upper extremity, and then it's guided, the tension, and it is coordinated with the information from vestibulocochlear system. So it's coordinating the position of the body, position of the limb. So then, conscious are led with tactile information through the posterior funicles with fasciculus gracilis and cuneatus. They are relayed in nuclei like the touching information, and then also they have some side information going to the cerebellum with the gracilo or cuneo cerebral tract. So, this is position information and tension information. So this is information about how the motion was executed. Where is it? Our hand. Where is it? My feet, etc. The second, unconscious. This is an unconscious information which is very frequently from the automatic motions. So it is led directly by the spinocerebellar tract. So it's information typically from cyclic movements, those which are automatic, so stairway stepping, also bicycle riding or running, hunting, running for the antelope by the leopardus and other things. So this is unconscious. Those cyclic information, where they are occurring. These information are made by two systems. One is Golgi tendon organ. So this is an ending which is in the interface, typically in the interface of a tendon and muscle, so musculo-tendinous interface. But also those similar organs, similar sensors are in ligaments, which are informing us about the tension of the capsula of the articulation. The second information is then made from this structure, which is seen here, and this is a ending which is sensory ending about the tension and motion of this spindle. This spindle is a specialized unit, muscle spindle, which has intrafusal fibers, and about them, the motion of them, a tension, forming the back information about the tension and execution of a motion from the muscle. So the distribution of innervation is very also important. So I have here one note about radicular territories. We know which territories are innervated by some levels of spinal segments. So here is easy to see where is C5. C5 level is typically biceps and deltoid muscle. So what is the nerve which is innervating biceps, and which nerve is innervating one and second? Yes, and musculocutaneous is biceps, and axillary nerve. Axillary nerve is a deltoid. Yeah. So you can see here that those muscles are generated from one somatome. One nerve is innervating them, and we had the lecture where was the plexus, like those radiculi are changing positions and going together. So this is a C5. C6. C6 is again this one. This is again the biceps, and this muscle is? Yes, very well. And then C7, it is more complicated. Yeah? C7 is generally here, this one. This is the back. Yes, and this one? Pectoralis. And here you have this. So this is when you remember the cat which is standing on the four legs, anterior, posterior. So this is the back of the whole back segment. So this is important information, which is then going back from those radicular territories, from the sensoric, because we are talking about motor innervation of a muscle. This is a motor nerve. But every motor nerve has also some sensoric part, which is sensoric from the motion from the muscle. Not sensoric from the skin, because the skin is different, yeah? Skin is here, and the muscle is a little bit different. So sensoric is a touching, and here is a sensoric information, which is a proprioception. So in lower extremity is the same. Yeah, this muscle, this is easy, so it's a, yeah. Partially, it's a quadriceps, again quadriceps, and here tibialis anterior, 5, some gluteal muscles. Yeah, different one, and dorsal, typically dorsal are S1 muscles. About sensoric information. Also the skin information has impact into the motion. Why? Because your feet or your hand is touching. So we have then the sensations which are called fine tactile perception, rough perception, and also nociception. The rough is also sometimes called crude. So fine tactile perception is led by posterior funiculi, led by the fasciculus gracilis and cuneatus, and this fine reception is from tactile discs, typically on the interface of the skin between dermis and epidermis. So this is very important. So this funiculus, they have a very distinct localization. So you are with the fine very well discriminating the structures, the position. The crude, also rough perception is led by spinothalamic lateral tract. It has a very wide projection because they are connected with the other segments. So probably up to 17 segments, they have a projection. So then it is not too easy to understand where you are touching to the skin, especially in the, this is for vibration, this is for the sensation of a pressure when you are stepping on the floor, etc. And then we have also nociception, because also the pain and cold and heat feeling is important for motion. So they are led by the unmyelinized free endings. And those free endings, what is free ending? Free ending is some distribution of dendrite, and the information is going then from several territory and then is led back. What it means, that is unmyelinized, about the velocity of the projection of the electric potential. So because it is unmyelinized, so it is leading the information very slow, or more slow than the myelinized. So the information about pain and heat is projected into the spinal cord and into the brain slower than the sensation of touching the structure. So what is the rough perception? Rough perception is done by the, typically also by the endings which are on the bulb of the hair. And this rough perception is feeling of the wind, for example, in a, you know that dogs and mouse, they have also the barb, the long barb, also the long hair, which are informing them about the space. So this is a rough perception. The receptors. So the receptors are localized in the skin. They are localized in the dermis. They could be on the interface between epidermis and dermis. So they are different structures. Some are more specialized, rapidly adapting, rapidly making information. This is called Meissner. And then we have free endings. Those free endings could have, they are nociceptor, thermoreceptor, and mechanoreceptors. They have unmyelinized, and they are used for nociception. Those are free endings. So they are in the near layer, near to epidermis. Then we have a specialized tactile things which are called Merkel cell endings. The Merkel cell ending has several, I think, hairs, and then is connected to the dendrite, and it is able to produce the information, which is a slow adapting mechanoreceptor. So this is typically for mechanic information obtained from the skin sensation. Then we have a specialized structure which is called ruffini. And this ruffini is very similar to the structure of a spindle. And then we have the next one. The next one is localized in the subcutaneous fatty tissue, and it is a Pacini corpuscle, which is fast adapting. So this is very well informing about the vibrations and other things, which is localized in the subcutaneous layer. And the Pacini has only one ending or starting part, because the information is going this way, and on the surface is some capsula which is making it too large, to be larger, and to obtain the information about movements of subcutaneous skin. And this is the last one, which is a Golgi. And Golgi, it is the ending which is in the interface between muscle and a tendon. So back, the information is now created there. So we have some impulse, and the impulse is then led, and once again is led from dorsal or ventral ramus nervi spinalis, and here we have every time the pseudo-unipolar, which has then projected into the spinal cord. Then in a spinal cord we have a different situation. Some fibers, like here, are not relayed here, so this is typically cuneatus and gracilis, and we know that it is fine, so tactile and conscious proprioception. This proprioception is led by this segment which is localized here. The second one is then relayed somewhere and then is going upwards also to the central nervous system. So what is the relay in the spinal cord? So for us it's important that the way of tactile has a no relay. in spinal cord. The first relay is in medulla oblongata, where is nucleus gracilis and cuneatus. The other, they have relay here inside. So in substantia gelatinosa, which is the most dorsal, this is a nucleus which is relaying pain, heat and cold. And then is going to the tractus spinothalamicus lateralis, lateral spinothalamic tract. So this is what? This is a nociception. Then the next one, which is more centrally, is called nucleus proprius. The proper nucleus is leading this rough or crude tactile through the tractus spinothalamicus anterior spinothalamic tract. And the next, last one, localized the most centrally, is a for inconcious. Proprioception is a for spinocerebral tract. So those are relays which are inside the posterior horns, and they are related to the three different feelings. The substantia gelatinosa, more dorsal, nociception, then rough or crude tactile, which is more central, and completely in the central localization is unconscious proprioception. Then those informations are led by those tracts. So this is upwards going the tactile and conscious proprioception. Yeah. Here we have a spinocerebellar and spinocerebral, which are unconscious proprioception, and anteriorly is a tract spinothalamic which has a nociception. So then the territory of the dorsal spinal cord is important for conscious sensations, tactile and proprioception. What is led directly to the central nervous system through the thalamus. Then the nociception is anteriorly, it's in the front of anterior horns, and lateral part is for cerebellar sensations of emotions, so cerebellar proprioception, unconscious. So spinothalamic tract, once again, spinothalamic tract is made from three neurons. First neuron, pseudounipolar, is in spinal ganglion. Every time in spinal ganglion. Then the second is going to the nucleus proprius. Nucleus proprius is somewhere here. And then this is crossing to the other side and going through the spinal cord, through the medulla oblongata, in medial lemniscus, and going then to the what is this structure? So thalamus, and from thalamus, this is a first, and the third neuron is then distributed to the cortex. So lateral spinothalamic tract. The lateral spinothalamic tract is important for sensations of the pain. So substantia gelatinosa is relaying. This is relaying pain, heat and cold. So then from substantia gelatinosa the information is going again into the thalamus. This is a second neuron. And then the third is to the cortex. So projection to postcentral gyrus. The conscious proprioception, fasciculus gracilis and cuneatus, the same way, is going through the spinal ganglion, and then the information is going directly this way to the nucleus cuneatus or gracilis, cuneate here, and then with the lemniscal crossing, then to the thalamus again, and then to the cortex. So also here we have a 1, 2, 3 neurons. First is here, the second is in oblongate, and the third is in the thalamus. So every conscious, every nociception, and every crude perception has 3 neurons. And every time the first one is in a spinal ganglion, and the third is in a thalamus. Fasciculus spinocerebralis, we have 2. One is anterior, called Gowers. The anterior is using muscular spindles and Golgi tendinous bodies, and also receptors in capsulas of articulations and also ligaments and tendons, and they have a crossed and uncrossed fibers. So this is a unconscious extero and proprioception. So then the first neuron is again in a spinal ganglion, the second is in a cornu posterior, and then the second neuron projection is directly projected into the cerebellum. It has a crossed and uncrossed part, so then it is going through this way to the cerebellum. So the second neuron of Gowers is going into the pedunculus cerebelli superior, through the superior, and to the pars vermiana spinocerebelli, so the spinocerebral vermian part. The second spinocerebellar posterior is called flexic. This is a flexic, and this is a Gowers. And this has also the very similar propagation. So it is from Clark column, from Stilling nucleus, again the same way. They have uncrossed fibers, and then it is going to the cerebellum with the fibers which are uncrossing, and they are going into the, about the position sense, they are going to the cerebellar, spinocerebral part, so the paleocerebral part. So then the information is the conscious information is going into the cortex. The information has a somatotopic organization also in gracilis and cuneatus part, and then every projection into the cortex is relayed in the thalamus. So everything is going from lateral spinothalamic tract, for example, is going to the thalamus, and from the thalamus this is distributed according to the somatotopic organization, very similar way like in motor cortex, but different parts. So this depending that we have the largest territory of feeling from a tongue, from tongue, from a thumb, and from a hallux or planta. So this is a little bit different than in motor cortex. So what is somatosensory cortex? Somatosensory cortex has two important functions. One function is relay to the motor cortex, and it is a feedback from motion execution, and the second is very important information, which is for space recognition. Space recognition according to the localization of your body parts, because this is an important coordination between motions and mind. So this is postcentral gyrus, and we know, probably you know, that we have territories which are under classification of Brodmann area. So Brodmann described the cortex according to the cytoarchitecture, the layering, the thickness and ratio between layers. And motor cortex is a 4. We know that, probably you should know that it is a 4. And then we have somatosensoric territories, which are divided into the 1, 2, 3 territories. So this is a 1. 1 is a tip or top of the gyrus. Then we have subterritory 3B and 3A and 2. And we see here that the proprioception information is going into those parts of the gyrus. The top here is a tactile, and here is a proprioception. And what's the reason why we have two territories for proprioception? This proprioception has direct influence to the motion. Yeah, this is a real feedback from the muscle, real feedback from the tendon. And then the information is used for the next step of the motion, next point of a chain of sub-motions. And the second information is going this to this, and here is a short way to the fifth territory, and the fifth is parietal association cortex, which has a very important role in recognition of the space. And the recognition of the space here, this territory, space and occupation of a space by your body parts. So when some patient has problem in this cortex, and typically it's associated with prefrontal and premotor cortex, those patients have problem to recognize his or her upper extremity, for example. So this is a disease which is called corticobasal degeneration. So they have a sign which is called a lion limb. So then, he or she is not able to recognize that this is my hand, this is my body part. This is hand of someone else. So then we know from those neurological disorders that this cortex has a key role in recognition of the human body parts position. So then here is a some logic structure of this sensory cortex. One is side by side with the motor, the second for the recognition. And you know that we have other association cortices, and they are recognition of the visual inputs, of a hearing inputs, and here also the body inputs. So this is the space where are associated all sensoric informations together, and they have very important connection to the frontal cortex, reciprocic, because when you something planning to do, so then you have to recognize your position of the body, recognize where you are, if outside is raining, and other things. So this is a very intrinsic and important. So now we turn to neuromuscular spindle. So neuromuscular spindle is, I have said, that it is a specialized unit inside a stripped muscle made from stripped specialized muscular cells. They have a motor and sensitive ending, or sensoric ending. They are made from modified cells, and the spindle has innervation from gamma neurons. And the information, what is created here is here. This is the blue one are endings, spiral-like endings, which are in the middle of the spindle. So this is fibers which are inform us about the tension and intensity of contraction and velocity of it. And gamma neurons have endings at the tip, at the sides of the spindle. So then the system is straight way of information about the inner tension, inner velocity of contraction of the muscle. The neurons are going the same way here. So then we have also the endings to the muscles. So then it has a very similar stimulation for those spindles and real motion executing muscles. So neuromuscular transmission. Neuromuscular transmission is a plate and is a little bit different in a stripped and in smooth muscles. In a stripped muscles, on it is this structure, which is a motor axon, and the Schwann cell is covering the interface between muscle and neuron, and the muscle has a sarcolemma like a brush, and this brush sarcolemma is under stimulation of acetylcholine. So when the stimuli are going here are vesicles of acetylcholine, like everywhere in the peripheral nervous system, and then this is something like a synapses, but it's not synapses. The acetylcholine then is activating the membrane of a muscular system or muscular cell, and then the electric potential is created there. So in autonomous it is different because we have adrenergic and cholinergic. Almost all sympathicus has adrenergic, so noradrenaline, and cholinergic is in parasympathicus. So then quite a little bit different mediators, but important is that the axon is unmyelinized and the endings are varicose. They have this sarcolemma brushing, so then the transmission of the electric impulse is slower, but it's more intense. So then you know that smooth muscle is more strong, long-lasting contraction, but very, very slow. So, and now at the end we repeat the informations. So, planning execution. We need motor system and sensoric system. Motor system is planning and execution and for control, for follow-up. And a sensoric system is also important for superficial and proprioceptive information, and it is important for back information, for feedback. The control of the motor system is under the proper tension of the muscles. So, where we have our sensoric system. The sensoric system is going into the central nervous system through the spinal nerve or through the sensoric nerve of a head and neck. The major is a fifth nerve, but it's not only a fifth nerve, mainly fifth nerve. So then we have information about touch, pain and temperature. Again, touch and proprioception, pain, temperature. And the first neuron is localized, is ganglion. In spinal cord, it is in spinal ganglion. In trigeminus is in trigeminal ganglion. Then this neuron is relayed. Typically, proprioception and touch, the conscious, is relayed from the spinal cord in the oblongate. Nociception, it is in the spinal cord at the level of the segment. Everything now, from head and neck and body and extremities, is then relayed. So here we have first neuron. Here is a second, and everything has the third neuron in the thalamus, and then this is projected according to the projection. So then back, so this is a sensoric part. The motor has a very similar distribution in a cortex, and we have two ways. Head is a corticonuclear, tract, and here is a corticospinal. When you look at the American books, very frequently you can see corticobulbar. Why corticobulbar? Because it is in bulb. Bulb is another English term for oblongate. So then we have several ways of information distribution. So ascending, again, this is I think, very extreme schema, but when you look directly for this, it's nice to see how they are associated, those information. This is L4. L4 is going in the middle part. C2 is going from a lateral. And when you see here gracilis and cuneatus, so he is relayed, and then is going crossing to the, this is decussation, sensory decussation of lemniscum, and this is a medial lemniscus, and here is also territorially seen how they are projected into the thalamus. The third neuron then is distributing the information to the, this is the second one, and here is the first one. On the other side, here is the distribution and several leg, arm, so leg, arm, and a head, hand, not the hand, head. They are going to the mesencephalon, pons, medulla oblongata, and then this is going to L4. This is sensoric again. And this is then crossing the information, which is about temperature, dorsal, from dorsal ganglion, from spinal ganglion, so it is nociceptive. And here is information. Again, and again, the third neuron, first is here, second is here, and the third is in the thalamus. Yeah, last one is a motor. And a motor has the same distribution, and we know that the tracts are crossing partially 80% of the decussation and going down, and has execution to the several layers. So look at those schemas which are from Gray's neuroanatomy, the large Gray's neuroanatomy, where are localized. So then you very easily could understand the distribution of those somatotopic organization. So now very important information about lemniscal system. I have said that there is some lemniscus. So what is lemniscus? Lemniscus is part, we have information which is going into the cuneate, ergracile nucleus, and the fibers then, this is a second neuron, and fibers, axons of them, going to the sensory decussation, crossing the midline, and going medially upwards, next to the midline, upwards to the thalamus. And this is a posterolateral nucleus of ventral posterolateral nucleus of thalamus. Where is lemniscus localized? It's localized here. What is this? This is substantia nigra, and this is a nucleus ruber. So lemniscus is in the middle of them here. What is here? This is a motor. So typically you can see here motor. So lemniscus or lemniscal system is a system which has a first neuron in a spinal ganglion going through the fasciculus gracilis and cuneatus, and then it is relayed in the nucleus gracilis and cuneatus, crossing to the other side also at the level of the bulb or oblongate, and then is going to the ventral posterolateral nucleus, and then with tractus thalamocorticalis it is distributed into the postcentral gyrus. So this is lemniscal system, very important for neurology again. So this is a schema of it again. So lemniscal system going to the, from a first neuron to the oblongate. Here is a second neuron, and lemniscal crossing is going, and lemniscus medialis is going next to the nucleus ruber, and substantia nigra, and then is going to the thalamus, and from thalamus is projected to the cortex. So spinothalamic and spinoreticular system. So they have also pseudounipolar cell, a spinal ganglion. They have a nucleus proprius in a dorsal horn, and from a dorsal horn they are relayed and going to the other side and going with spinothalamicus lateralis and anterior, and they are going upwards to the thalamus. So here you have first neuron, second neuron, and the third neuron, and then distributed to the so this is a lateral spinothalamic, and this is anterior spinothalamic. They lead pain and temperature, about heat and cold information. So again, relayed here, first neuron, second neuron, and then through those, and this is led into the so-called spinal lemniscus, the first one, which was localized here, was medial lemniscus, that touch, and this is spinal lemniscus going again to the thalamus, and here is a third, and again the same information, not the same information, the same distribution of information. Summarization of a motor system. Motor system has a first neuron. This is a central neuron. Central neuron is in a cortex. From the cortex, they produce axons, and they are going through the mesencephalon, through the ventral pedunculus, crossing through the pons, going to the pyramid, and when the pyramid is then changing to the crossing, so the decussation, and the decussation is going then 80% laterally and 20% medially. And then here is a direct relay to the motor neuron, which is localized in the anterior horn. Very frequently is relayed by the interneuron. So cortical pathways, they are used for voluntary motions. The brainstem, motor modification. So they have the cortical pathways contains motor corticospinal tract. This is what is here seen. This is corticospinal crossing, and this is important for these voluntary motions. The other tract, corticonuclear, corticorubral, corticotectal, corticoreticular, and corticointerstitial vestibularis, these are additional tracts which are modifying the other tracts, and the other then those modifying the brainstem pathways. And the brainstem pathways are motor modifications which are known for us because they have a rubrospinal, tectospinal, reticulospinal, and vestibulospinal tract. So we know that they are important for modification of some involuntary motions. So the summary of the way of motor. So one way is a leg, one way is a hand. The way of hand is seen here, crossing in the medulla oblongata and then going down 80% crossing, 20% non-crossing. Seen here the somatotopic, again, organization. Crossing, this is decussation of pyramidum. And 20% non-crossing going down. Rubrospinal tract. Rubrospinal tract, we know that is from rubra nucleus in lateral fascicles going, crossing the midline at the level of midbrain, and then is going side by side with corticospinal tract. And the other tracts are going very similar way from a midbrain. This is from colliculi. So this is a tectospinal tract. So remember that there is first neuron nearby colliculus crossing the midline and going down and going in the anterior fasciculi, and then is modifying the spinal cord neuron activity. This is a vestibulospinal. So vestibular nuclei, and from vestibular nuclei again in anterior horns, anterior fasciculi, they are able to modify the activity of a cervical or lumbar spinal cord. So, and then it is, I think, cerebral controlling system. Cerebral controlling system is the system which is acting after the information which are proprioception, sensoric inputs, and body positions. The information is obtained from medulla, so from spinal cord, then also from cranial nerve, and also from cortex. Everything is transducted from Purkinje cells. Probably you remember that the Purkinje cell is which has like a deer horn, and this is very important because it's excitation. They are able cerebral nuclei inhibition, and also they have very important inhibition because cerebral nuclei are under-inhibited, so they are released. So the inhibition factor of this is very important. So this is a main regulation of the motion. So this is really plan of a complex motion. So they have those motions have a template in some memory circle in a cortex, and the same is in a cortex of a cerebellum. So they have two templates, and they are then what you would like and what is executed. The Purkinje cells are able to control. So they have online data from proprioception and somatosensory special senses, and also in the same time the information from cortex, and they are continually regulating and coordinating the template which is in a cortex with the template which is in a cerebellum, and what is the deviation from the plan, from the template of the motion. So they associate also follow-up of a tonus of muscles and balance maintenance through the postural anti-gravity muscles, yeah, and also through the through the vestibular nuclei. So the relay of cortex and the cerebellum is through the nucleus dentatus, so dentate nucleus, and through the reticular formation. So cerebellum has important influence into the cortex, into the postcentral and precentral cortex. So they have a relate to the sensomotor way, and then also they have a relay which is downstairs to the olivary nucleus, inferior olivary nucleus, and also nuclei which are in reticular formation. So this is a relay of a cerebral controlling system, which is complicated through the many interrelate centers. So red nucleus, so for automatic motions, reticular formation for the tonus, which is depending on the sleeping or wake up, etc. So neurocerebral connection is this connection. So this neurocerebral connection is from the Purkinje cell through the dentatus, and then through the dentatus to the thalamus, and the thalamus to the cortex, and then from the cortex we have a projection into the spinal cord and motor, but the same way the projection is also to the cortex. And then back, the template is follow-up, and Purkinje cells are modifying the activity of dentate nucleus. If we look at the cerebellum, probably you can see cortex and nuclei, dentate nucleus. So very similarly, they are organized, those gray matter structures, like in a cortex. So cortex and basal ganglia, cortical and subcortical. So paleocerebral connections are connections which are to the spinal cord directly, not to the cortex. Spinocerebellum, they have also Purkinje cells, but in the more medial part, and then they are relayed through this underlaid globose and emboliform nuclei in paleocerebellum, and through the paleocerebellum back to the red nucleus. So there is a control. Paleocerebral is they have no connections to neocortex of a telencephalon. So our last 10 minutes will be about the speech, or 5 minutes. Because speech is a very important motor and sensoric integration, the speech and the regions which are important, so they are important centers. So we have two main. Broca is a motor center, and Wernicke is a sensoric. So Broca area is in a prefrontal, in gyrus frontalis inferior, in area 44-45, and when there is some injury, typically ischemia or bleeding, more frequently ischemia, the patient has a problem with motor speech process. So the speech is not processing, she or he is able to understand what you have said him, but is not able to say, I have any problem, I cannot move with the limb. So they are able to understand what you are saying, but not to reply to you, so not answer your questions. The second area is Wernicke, 39-40. So there is a much more variable part, because the parietal cortex is very variable from the, and plastic for the distribution of those centers. So this is more plastic than motor. The motor speech center is typically at the dominant hemisphere. So in a right-handed, I'm a right-handed, so my motor is from about 90% on my left hemisphere, not on the right. But there are some situations because the cortex could have some plasticity also. So some people have active both sides. Sometimes you could have the non-logically on the right side if you right-sided. Typically when the patient has some developmental disorder on the dominant hemisphere or long-lasting process developing there, slow-growing tumor, for example. But in general, it is a fixed. The function is not possible to change after injury. In left-handed people, it's about 50% in the dominant hemisphere and 50% on the left. So then it's very important when we perform the plan of surgery in the brain, we do, as radiologists, functional MRI of those patients. When the tumor is nearby the localization of the speech center, so then we localize the functional MRI, the activity of the center. So this is very important. So Wernicke is a much more flexible. You could have it on the same side of the Broca, on the other side, if it is this is an angular gyrus, so it could be more parietal, more occipital. So this is a region where we have those association centers. This is very close to the association. This is association center of visual cortex, and this is a hearing. So then we have a relation to the association centers made from, or changing information from the visual or the auditory impulses. So then, those associations, so auditory typically is area 22, you can see it here. So this is a nearby primary cortex, or somewhere here is a primary auditory. And there's a visual. So the primary visual cortex is here, and this is the association visual. So the speech and the process of the speech is depending on the sensoric information and the motor information. The sensoric information is important in understanding, and motor center for the execution. Both centers are connected together with this band of white matter, and sometimes the patient could have also the bleeding or ischemia here, and they have disconnected those centers. So this is another part of problem. So when you have the problem here, so this is called motor aphasia. Motor or expressive. And here is sensoric. Yeah? He is not able to understand. He is producing some nonsenses and not related speech to the situation. So the speech centers, then they have connections to auditory cortex, visual cortex, and this is in angular gyrus Wernicke center, and this is Broca, and here is a superior longitudinal fascicle which is connecting those centers, and then this Center is involving motor. Motor is producing the guiding for the speech centers, which are mouth and tongue motor cortex. So the process of the speech is probably in the frontal cortex, somewhere else, but typically sensoric information. I see you are sleeping, so I have here the association from the other inputs, from hearing, you are talking together. Then I have here something which is forcing my speech, forcing the density of information or slowing down, and then here I am executing my speech. Yeah? And the problem then could be here. You are not able to produce the speech. Then you could have also here. You could have a paralysis or plegia of the tongue. When you have a plegia of the tongue, you are not able very well to modify the voice. When you have plegia of a vagus, you are not able to make a voice in a larynx. So it could be a problem, but it is not the problem of the speech creation. The second could be when you have damaged this territory, so you are not able to understand what you are hearing, or when I hear speech, I don't understand what is it. Yeah? I don't understand what I see. So, and then those speech centers are very, very important center for our minds, for our, I think, individuality, because they are communicating with the other functional things which are very important. So we have some executive functions, so they are localized in the frontal lobe. So this is I would like to do. What is the proper situation now, of what is proper to do in this situation. I'm now talking about neuroanatomy, not talking to you some jokes. Yeah? When I could have a problem with the frontal, I could hear to say you some improper jokes which are not related to this situation. So then we have a praxia. Praxis is something which is motor related and also motor control related. So when I have this problem here, I'm not able to make a voice. And then here is also spatial disorientation, spatial problems which are called neglect or this alien limb. And then for language creation is also important perception of the outer. And what is important? Also you can see that it is very related into the conceptual path. It's interesting that those semantic conceptual system is very close to the system which is called limbic system. And there are problems which are localized in a temporal lobe. They are very frequently associated with the neurodegenerative diseases like, for example, Alzheimer's disease. In Alzheimer's disease, those patients have problem to make sentences with sense. So they are not understanding. I see you. You are here every my lecture. You also one is escaping also very frequently because you are near. I know your faces, also those faces. When you are not recognize your mother, your daughter, so then this is a very important to the lesions in temporal lobe. And also the memory is very important here, because the executive function is very important for memory. If you have a patient with a frontal syndrome and they have frontotemporal lateral degeneration, specialized neurodegeneration, brother of Alzheimer's disease, those patients are behaving not correctly for the situation. So they are joking. They could urine in the angle of the room, etc. So such a strange things. Or they could have the problem with creating the voice, understanding to the speech. So this is probably, you know, that one of the most interesting and important Hollywood actor now is suffering from this disease, which is a temporolateral degeneration. So the semantic form, these people are not able to relate to the situation. They are not able to understand. They are not able to answer to the questions. They are completely cut off the environment because they are understanding to nothing, even if they are able to create a voice, create the speech. But they have not the control of the supervision of the cortex, where we have this part of our mankind. So this is a behavior, this is the understanding and to create the semantically proper speech. So finally I have to say that we have some symmetric brain with asymmetric functions. The brain is not symmetric also completely, that left is completely related to the volume of the right one, because our hemispheres have splitted functions. So you know that we have a right-handed, left-handed patient. So this is one of the most important. But in general, in the left hemisphere, it's important, and now we are talking about the right-handed people. Verbal, linguistic description, the left hemisphere is important for mathematics, analytics, and it has direct link to conscious functions. On the right hemisphere is much more important for the people who are typically artists, because they have there some non-analytical, non-mathematic, non-systematic, but more emotional. So this is a musical, geometrical, some other important. So they have also link to consciousness, but it's a little bit different. So asymmetry of the brain is developing because the evolution, or God, gave us the possibility to use the whole capacity of the brain, even if we don't know what is needed and where is the center for everything. But we could understand, typically from the neurological disorders which are occurring in those patients after ischemia, after tumor, after resection, after injury, what they changing in her or himself, and then we can derive the information about the functional things in the brain. So, thank you for your attention.